Hello, my name's Ikra and I'm a dermatology registrar in the UK. Today I will be talking about common skin presentations. I will briefly begin by talking about why skin presentations are important, and then there are two cases that we will cover through this presentation, and finally I will summarise the key take-home points. So why are skin presentations important? Approximately 1/5 or 20% of visits to GPs and to emergency departments are because of skin complaints. It's important to recognise that both common and potentially life-threatening skin conditions can occur in inpatients. Promptly identifying serious skin disease can significantly reduce morbidity and mortality for patients. In this presentation, I will focus on a couple of common skin presentations which are important for you to be able to identify as foundation doctors. Our first case is that of a 3-year-old girl presenting to the emergency department with an itchy rash on her face and a fever. Her parents report that she has been off her food and has been miserable the last couple of days. She has no significant past medical history of note, although her parents do report that she has had dry skin since being a baby. She takes no regular medications and has no known drug allergies. There is a family history of atopy, as her father has both asthma and allergic rhinitis. On examination, you notice vesicles and punched out erosions on her face, with some golden crust on the cheeks. This is seen in the photo on this slide. This first case is typical of a child with atopic eczema that has become infected with herpes simplex virus, resulting in eczema herpeticum. There are many different types of dermatitis, and for the purposes of this talk, I will focus on atopic dermatitis and also cover venous eczema, which is a common presentation in hospital. Atopic dermatitis, also known as atopic eczema or eczema, is a very common skin condition which affects approximately 15 to 20% of children and also a large proportion of adults. It is part of the triad of atopy, which also includes asthma and allergic rhinitis. In atopic dermatitis, individuals have an impaired skin barrier, which makes their skin more susceptible to irritants and allergens. Triggers for atopic dermatitis may include irritants such as soap or harsh chemicals, or there may be allergens which incite a contact allergy, such as fragrances. Itchiness is the hallmark of atopic dermatitis. This slide shows a variety of images showing the clinical presentation of eczema. In babies and infants, eczema typically occurs on the face, so on the cheek area, and it can occur on the extensor surfaces of the limbs. However, as the children grow older, for older children and adults, eczema most commonly affects the flexor surfaces, so the creases behind the knees and also behind the elbows. Eczema can have other presentations, so some individuals may have hand and foot eczema, for example. And in darker skin, the eczema may be masked as the redness isn't as visible. In darker skin as well, eczema can result in post-inflammatory hyperpigmentation. This is shown on the images on the bottom row, in the middle and on the left, where patients with skin of colour have darker patches left behind as a result of the active eczema. Treatment for eczema involves a multi-step approach. This includes use of a regular emollient, a soap substitute, and topical steroids. If topical treatment is not successful, then patients may be referred for phototherapy, and they may receive either narrowband UVB phototherapy or PUVA. Systemic treatment options are also available, and you do not need to know a lot about these, but the treatments that we use in eczema are methotrexate, azathioprine, and cyclosporin. If all these treatments are not successful, then biological treatment can be considered, and recently dupilumab has come on the market and is a successful treatment for severe eczema which is not responsive to the other treatments listed on this slide. When it comes to prescribing emollients, it can be quite confusing to know which emollient to prescribe, as there are such a variety available on the market. This emollient ladder shows how different topical preparations of emollients vary. On the bottom of the ladder are light preparations, which are very watery. These include lotions, so for example E45 lotion, Cetraben lotion, and Dermal 500 lotion, which is often better used as a soap substitute. Then we move on to creamy preparations, so this is creams such as Epimax cream, Cetraben cream, which are good for daily use as they absorb quickly into the skin and don't leave a greasy residue. Greasier preparations such as white soft paraffin and hydromol ointment are good for very dry skin, but not very easy to use because they are quite sticky and greasy. These are probably best used at night in patients with dry skin, with a lighter preparation such as Cetraben cream used during the day to keep the skin moisturized and hydrated. Similarly to the emollient ladder, there is also a steroid ladder, which you may have come across before. At the bottom of the ladder, we start with mild topical steroids such as hydrocortisone 1% ointment, which is generally very safe to use in babies, children, and adults. This may be combined with antifungal or antimicrobial ingredients in the form of Fusidin H and Canesten HC creams if there is suspicion that there may be a superadded fungal or bacterial infection. Moving up the ladder are moderate topical steroids, which include Umivate and Betnovate RD. Again, these may be combined with antifungal and antibacterial ingredients if we suspect that there may be a infection of the skin. And this is normally in the form of Trimivate cream. Moving up the ladder further, there are potent topical steroids. These include Betnovate ointment, and at the very top of the ladder are super potent topical steroids, including Dermavate ointment. In general, these should not be used without seeking dermatological advice beforehand. As a general rule, for infants and young children with active eczema on the face and body, the topical steroids listed on this slide can be used. It's important to ensure that there is no evidence of either viral or bacterial infection before topical steroids are used, as they can exacerbate eczema hepaticum in particular and cause this to spread further. On the face, hydrocortisone 1% ointment can be used twice a day for a couple of weeks until the eczema begins to settle, and then slowly reduced by switching to once a day, alternate days, and then every other day over the course of weeks. For the body, Umivate ointment is safe to use in a similar manner, so twice a day for 1 to 2 weeks until the eczema begins to settle, and then slowly reducing to once a day, every other day over the course of weeks. Tailoring steroids down in a stepwise fashion is important in keeping the eczema under control and ensuring that it does not flare again quickly. For adults, Umivate ointment is safe to be used on the face and neck area. Periorbitally, hydrocortisone 1% ointment should be used, as the skin here is very delicate and thin, and there is an increased absorption of topical steroid. On the body, Betnovate ointment or Elecon ointment, which are both potent topical steroids, may be used twice a day for 1 to 2 weeks until the skin improves, and then weaned and tailored down in a stepwise manner. Other things to consider for a patient presenting with severe eczema are medical photography. It's useful for patients to have baseline photos so that any improvement or deterioration in their skin can easily be recognized. Also, if there is discharge or weeping of the skin, it's important to take bacterial skin swabs and send these to the lab. Similarly, if there are any blisters or vesicles, a sterile needle can be used to pierce the blisters and a viral skin swab sent to the lab. If patients are systemically unwell or they have poorly controlled eczema, then baseline bloods are helpful, and also bloods as workup for the systemic treatments that I have touched on earlier. As mentioned earlier, eczema may become infected. The photo on the left shows eczema hepaticum, so you can see the monomorphic punched out erosions on the neck and upper chest of this lady. And on the right, you can see golden crusts around the lips of a child, which is suggestive of bacterial infection. Venous eczema is a very common skin presentation, which is typically seen in older patients. Often it is mistaken or treated as bilateral cellulitis. However, it's important to be aware that bilateral lower leg cellulitis is very rare, and more often than not, patients will have other evidence of venous disease. Patients typically have this eczematous, erythematous appearance of the lower legs, and it may be accompanied by lower leg swelling and some warmth of the legs if there is also superadded infection. Later in the course of the skin disease, patients may develop an inverted champagne bottle leg appearance, such as that demonstrated on the right side of this slide. This is caused due to inflammation of the fat and can result in quite tender and also erythematous legs. This slide shows the different stages of venous eczema, going from very mild disease to severe disease. On the mild end of the spectrum, patients may have telangiectasia or visible varicose veins, some edema. Later on, patients develop pigmentation due to hemosiderin deposition in the skin, so a brownish discoloration. They also may develop lipodermatosclerosis, as we have just discussed, with the inverted champagne bottle leg appearance, and also atrophy blanche. Later on in the stages of the disease, patients may develop venous ulcers, which can be poor healing and cause significant problems. Treatment for venous eczema includes leg elevation when patients are seated at home, use of a regular emollient to moisturize the skin, using a soap substitute such as Dermal 500 lotion to wash the skin in the affected area, and topical steroids may also be used to help settle inflammation. In addition, it's important to consider doing an ABPI so that compression bandaging can be used, as this is very successful in treating venous eczema and venous disease. It may also be beneficial to seek a vascular and tissue viability nurse review, particularly if the patient has leg ulcers. Moving on to our second case. A 58-year-old man presents to the emergency department with a widespread erythematous rash, which is covering most of his body. On reviewing his clinical observations, you notice that he is tachycardic, slightly hypertensive, and is also pyrexial. His past medical history includes hypertension, hypercholesterolemia, and he has recently been diagnosed with gout. His drug history includes simvastatin, ramipril, and recently he has been started on allopurinol. The image on the right of this slide shows the appearance of his skin. This gentleman is erythrodermic. Erythroderma is when there is erythema or a skin rash which is involving more than 90% of the body surface area. This is often preceded by or associated with exfoliative dermatitis, which essentially means that there is redness and peeling of the skin over large areas of the body. Most patients who present with erythroderma have a pre-existing skin disease, but this is not always the case. The images on this slide are typical for erythroderma. You can appreciate full body skin redness, and the photo on the middle of this slide shows some evidence of peeling of the skin as seen in exfoliative dermatitis, which may precede or be associated with erythroderma. As I mentioned earlier, erythroderma most often occurs in patients with a known skin problem such as eczema or psoriasis. However, it can be associated with drugs, and in our case, the patient was started on allopurinol, which is likely to have caused the erythrodermic skin. Other rarer causes of erythroderma are also known, such as pityriasis rubra pilaris, which may look like psoriasis, and also cutaneous T-cell lymphoma. If the cause of erythroderma is uncertain, then the dermatologist will arrange for a skin biopsy to be taken to help aid diagnosis. The treatment for erythroderma is mainly supportive. An antipyretic is given regularly to help treat pyrexia. Fluid balance must be monitored and charted regularly to ensure that the patient is not having significant fluid losses. A thick, greasy emollient such as white soft paraffin, liquid paraffin 50-50 ointment should be applied all over the skin 2 to 3 hourly to protect the impaired skin barrier and prevent transepidermal water loss. If a patient is septic, then a full septic screen should be undertaken to exclude other causes of sepsis. This includes taking blood cultures, chest x-ray, urine sample, and skin swabs. The patient should be covered with IV antibiotics if they are having fevers or are systemically unwell. Antibiotic choice should be guided by microbiology or by the most likely cause of the pyrexia. Any unnecessary medications or suspect medications should be discontinued. As I mentioned, in this case, allopurinol was the cause of erythroderma for this patient. Therefore, it's important to review the full drug history and also to be aware of any new medications that may have been started over the past 2 to 3 months prior to the patient's presentation. Finally, a few key important take-home messages. Always examine the patient fully so that you are aware of the full extent and distribution of their skin rash. Never prescribe oral steroids for patients for their skin without seeking dermatology advice beforehand. For eczema, psoriasis, and other common skin conditions, use the basic algorithm of an emollient plus a soap substitute plus a topical steroid. Ensure that all regular topical treatments are prescribed for patients on admission to prevent any flares of their existing skin disease. And finally, it's important to know that skin presentations can appear differently in darker skin types, so lighting is essential, and also making sure that you look closely and seek help if you're unsure. Thank you for listening. I hope that you found this presentation useful. If you have any questions, then feel free to get in touch and I will do my best to answer your queries.